Good evening, everyone, and welcome to the 8th presentation of the basic modules in infectious disease that is organized by Infectious Disease Forum of the Federation of Clinical Pharmacists of India. So, hi, everyone. I'm Dr. Arya Iskumar, one of the member of FCPA, and I am moderating the session for today. Today's topic is antibiotic spectrum, and also we had a good response on last module, that is antifungal spectra. And our speaker is Dr. Disha Thomas. She's been working in antimicrobial stewardship as infectious disease clinical pharmacist in Amrita Institute of Medical Sciences for over 4 years. And she has completed SIDP antimicrobial stewardship certificate program. And she has publications in various international peer-reviewed journals to her credit. Before we begin, I would like to give you some instructions. Firstly, the feedback forms will be available below the video thumbnail of FCPA website towards the end of the session. Secondly, the certificates will be given within 10 days of submitting the feedback form. The feedback form will be made available at the end of the session, and the slides of the presentation can be downloaded from the website, and the login is mandatory to download the file. So if you're facing any issue, we would like to hear from you. So feel free to contact us for any assistance through the email provided in the website. And if you have any questions throughout the webinar, please write in the chat section, and your questions will be discussed during the QA session at the end. I hope the instructions are clear. But before we start the session, I would like to inform you about the upcoming events. First is the CP Conclave 2023 to be held on 15th to 16th November 2023. It is organized by Amrita School of Pharmacy in collaboration with FCPA. Second is the CP Summit 2023, which is to be held in Pune, that is organized by Indian Pharmaceutical Association Students Forum in collaboration with FCPA on 25th and 26th of November 2023. Third is the ID Congress 2024, which will be held in ICRA Hospital, Calicut, in collaboration with FCPA from 19 to 21st of January 2024. The events need live in-person registration. So without any further ado, over to you, Dr. Disha.
Hi, good evening, everyone. Today, I'm going to discuss about the antibiotic spectrum. Sorry.
So our last module is about antifungal spectra, and we got a lot of positive response from all, and that was a success. And now today's topic is antibiotic spectra, and I again once more will tell you the upcoming events. We have CP Conclave 2023 to be held on 15th to 16th November 2023. It is organized by Amarda School of Pharmacy in collaboration with FCPA. Second is the CP Summit 2023, which to be held in Pune, organized by International Indian Pharmaceutical Association Students Forum in collaboration with FCPA on 25th and 26th of November. Third is the ID Congress 2024, which will be held in ICRA Hospital, Calicut, in collaboration with FCPA from 19th to 21st of January 2024. Now it's okay.
Hi, sorry for the delay. So today I'm going to discuss about antibiotic spectrum. Disclosure information. I do not have any relevant financial relationships with any commercial interests. So the learning objectives of today's presentation is to discuss criteria for appropriate selection of antibiotics, understand the mechanism of action and spectrum of activity of different classes of antibiotics, understanding how the coverage of each antibiotics guide in therapeutic decision making. So what is antibiotic spectrum? Every antibiotic is characterized by a natural spectrum of antimicrobial activity that has been precisely determined during the initial phases of its study, long before it is introduced into clinical practice. This spectrum of activity, which includes the strains that can be inhibited by the antibiotic, does not vary qualitatively, although the percentages also of susceptible bacterial strains in a species may change over time with the development of resistance. So there are certain criteria for selecting antibiotics. Those include host factors, antimicrobial activity, pharmacokinetic properties, adverse effect profile, as well as cost of the antibiotic. And coming to the host factors, it includes pregnancy, drug allergies, age, immune status, renal impairment, hepatic insufficiency, site of infection, and indwelling catheters, including prosthetic devices. So how do we use antibiotics? We use antibiotics as prophylaxis, empiric therapy, or as definitive or targeted therapy. So what is a prophylactic therapy? So prophylactic therapy is where the administration of an antibiotic is designed to prevent serious infection in a defined at-risk situation, such as surgical prophylaxis, and also for medical cases where in patients undergoing chemotherapy who are at a high risk of neutropenia and thereby they are at a risk of infection. So we'll be giving antibiotic as prophylaxis. So next is empiric therapy, where a clinical syndrome that may be due to infection is managed before evidence confirming the presence of infection or its cause is available. So an empiric therapy will be based on the local antibiogram of that particular region or the hospital. And next is definitive or targeted therapy, where antibiotics are aimed at microorganisms which have been confirmed as the cause of infection. That is after obtaining the culture and sensitivity report. So next, I'll discuss the mechanism of action of different antibiotics. So I strongly recommend you to attend the previous sessions on different types of bacteria, such as gram-negative bacteria, gram-positive bacteria, then anaerobes and atypicals. All these sessions taken by Dr. Sangeeta and Dr. Grace. So those sessions will help you to understand about antibiotic spectrum in a better way. So coming to the mechanism of action, the antibiotics will be interfering with different processes of bacterial metabolism. So first one will be, they will be interfering with cell wall synthesis, then with cell membrane, then protein synthesis, and nucleic acid synthesis. So based on the mechanism of action, we will discuss further. So first class of antibiotic is beta-lactam antibiotics, which are again classified into different subclasses. So they are penicillins, cephalosporins, carbapenems, monobactams, and beta-lactam, beta-lactamase inhibitor combinations. So the mechanism of action of beta-lactam antibiotics, as you all know, it inhibits bacterial cell wall synthesis by binding to one or more penicillin-binding proteins, which in turn inhibits the final transpeptidation step of peptidoglycan synthesis, thus inhibiting cell wall biosynthesis. The bacteria eventually lies due to ongoing activity of cell wall autolytic enzymes, while cell wall assembly is arrested. So again, the penicillins are classified into different groups based on the spectrum of activity. So first one is natural penicillins. So natural penicillin has got gram-positive coverage, which includes groups A, B, C, and G streptococci, virulence group streptococci, enterococcus species, and penicillin-susceptible streptococcus pneumoniae. Then it has got gram-negative coverage, which includes Neisseria species, and it has got anaerobic coverage as well. It will cover anaerobes above the diaphragm, and then Clostridium species, but not Clostridium difficile. Next one is penicillinase-resistant penicillins. The examples are nafcillin, dicloxacillin, oxacillin, and methicillin. So these antibiotics will cover methicillin-susceptible Staphylococcus aureus, group A, B, C, and G streptococci, and also virulence group streptococci. Next is aminopenicillins, and the examples are ampicillin and amoxicillin. So the gram-positive spectrum of ampicillin and amoxicillin are similar with that of natural penicillins. They will cover streptococci and enterococcus. And then the gram-negative coverage includes Salmonella, Shigella, some E. coli, Haemophilus influenzae, and Proteus mirabilis. Next is anti-pseudomonal penicillins. So from here onwards, the spectrum is it has got a broader spectrum of activity. It will cover pseudomonas as well. So the examples are piperacillin and ticagrelin. So the gram-positive spectrum is as with natural penicillins, and then the gram-negative coverage includes Salmonella, Shigella, then enterobacterial such as E. coli, then Haemophilus influenzae, Enterobacter species, Pseudomonas aeruginosa, and other enterobacterial such as Serratia and Klebsiella pneumonia. And next is beta-lactamase inhibitor combinations. We already know the examples of beta-lactamase inhibitor combinations such as amoxicillin clavulinate, piperacillin tazobactam, ampicillin sulbactam, and the newer agent ceftazidime avibactam. So the gram-positive spectrum is similar to that of include Staphylococcus aureus but not MRSA. And the gram-negative spectrum includes E. coli, Klebsiella, Proteus species, and anaerobes such as bacteroid species. So that's all with penicillin group of antibiotics. Then next we'll move on to cephalosporins. They're again divided into 4 major generations based on antimicrobial activity and resistant to beta-lactamase. So from moving on from first generation to fourth generation, we can see that the gram-positive activity declines, whereas the gram-negative activity increases. So, and the fourth generation cephalosporins have got pseudomonal coverage, and there is fifth generation cephalosporin which has got MRSA coverage as well. So coming to the first generation cephalosporins, which are cefazolin and cefalexin, it has got gram-positive coverage, which includes MSSA, penicillin-susceptible strep pneumoniae, group A, B, C, G, streptococci, and virulence group streptococci. Then the gram-negative coverage includes E. coli, Klebsiella, and Proteus mirabilis. And coming to the second generation cephalosporins, it has got similar spectrum to gram-positive coverage to that of first generation. And then gram-negative spectrum includes E. coli, Proteus mirabilis, H. influenzae, Neisseria species, and Moraxilla catarrhalis. Also, it has got some anaerobic coverage such as antibacterioid species and Clostridium species. Next is third generation cephalosporins. The examples are cefixime, ceftriaxone, ceftazidime. So when it comes to third generation, there is a variable spectrum of activity within the same class. For example, when it comes to gram-positive spectrum, ceftazidime has 4 gram-positive coverage, whereas ceftriaxone and cefotaxime are potent against Streptococcus pneumoniae. And when it comes to the gram-negative coverage, it has similar gram-negative coverage as with second generation, plus it covers Citrobacter, Enterobacter, Acinetobacter, and Serratia. Then when it comes to Pseudomonas, ceftazidime has adequate pseudomonal coverage, whereas ceftriaxone or cefotaxime does not have anti-pseudomonal activity. Next is fourth generation cephalosporin, that is the main agent is cefepime. It has got extended spectrum of activity. The gram-positive spectrum is similar to that of ceftriaxone, and the gram-negative spectrum is similar to that of ceftazidime. And also it covers beta-lactamase producing Enterobacter species. It has good stability against beta-lactamases and is a weak inducer of extended spectrum beta-lactamase enzyme. And the fifth generation cephalosporin is ceftaroline. It has got MRSA coverage. Next, we'll move on to carbapenems, the main agents being meropenem, imipenem, doripenem, ertapenem. So it has the most broad spectrum of activity of all antimicrobials. Carbapenems have activity against gram-positive and gram-negative aerobes and anaerobes. So the bacteria not covered by carbapenems include MRSA, BRE, Coagulus negative staphylococcus, Clostridium difficile, and Stenotrophomonas maltophilia. And one exception within the class is that ertapenem does not cover Pseudomonas aeruginosa like other carbapenems. Next is monobactam antibiotic. The main example is Aztreonam. It binds to penicillin binding protein 3 of gram-negative aerobes. And then the spectrum includes E. coli, Klebsiella, Proteus mirabilis, Serratia marcescens, H. influenzae, Moraxella catarrhalis, Providentia, Morganella, then other enterobacterials such as Salmonella, Shigella, and Pseudomonas aeruginosa. So thus, we have completed the beta-lactam group of antibiotics. Next, we will move on to glycopeptides. Glycopeptides also act on bacterial cell wall synthesis. So the bacterial cell walls are made of peptidoglycan that is formed when cell wall pentapeptide precursors ending in DLR translocate from the cytoplasm to the cell surface and are incorporated into nascent peptidoglycan by transglycosylation, forming crosslinks by transpeptidation to strengthen the cell wall. Glycopeptides are cell wall active agents exerting their antibacterial effect by binding with high affinity to the DLR termini of pentapeptide precursors in order to inhibit the synthesis of peptidoglycan. So the main agents belonging to glycopeptides are vancomycin and teicoplanin. So these are narrow spectrum antibiotics. They have mostly gram-positive coverage, and the gram-positive cocci includes methicillin susceptible and methicillin resistant Staphylococcus aureus and Coagulus negative Staphylococcus. And it also covers Streptococcus pneumonia, including penicillin resistant Streptococcus pneumonia. And then viridans group Streptococci, group A and B Streptococci, and also Enterococcus species. Then the gram-positive bacilli coverage includes Corynebacterium, Bacillus, and Listeria. It has got anaerobic gram-positive coverage as well, which includes Actinomyces, Clostridium species, including Clostridium difficile. Capsule vancomycin is the drug of choice for Clostridium difficile infection. And then Peptococcus and Peptostreptococcus. Then these are newer glycopeptides such as telavancin, dalbavancin, and oritavancin. So now we'll have a sample question based on what we have discussed so far. So the first one is 65-year-old male patient admitted with respiratory syndrome and provisionally diagnosed as LRTI. Amoxicillin clavulanate was prescribed and sputum culture was sent prior to initiation of antibiotic. The culture and sensitivity report showed Pseudomonas aeruginosa, which is pan-sensitive, that is sensitive to all antibiotics tested. So which of the following will you opt based on the culture and sensitivity report? The options are A, continue current antibiotic regimen, B, discontinue antibiotic, C, escalate antibiotic, and D, de-escalate antibiotic. You can post your answers in the comment box in the website. We'll discuss the answers at the end of this presentation. The next question is, 50-year-old female admitted with fever for past 15 days, took antibiotics from local hospital, and it was not subsided and was referred to a higher center where echocardiogram was done, which showed vegetation and was provisionally diagnosed as infective endocarditis. So in general, empiric therapy of infective endocarditis should cover Staphylococcus, both methicillin susceptible and methicillin resistant, then Streptococcus and Enterococci. So, which of the following antibiotics will be the appropriate agent based on their spectrum? The first option is ceftriaxone, second one vancomycin, C meropenem, and D amoxicillin. So, you can post your answers in the comment box and we'll be discussing it at the end of this presentation. Next, we'll move on to lipopeptide antibiotics. So these antibiotics causes rapid depolarization of the membrane potential, which causes inhibition of protein, DNA, and RNA synthesis, and it exerts concentration-dependent bactericidal activity. And the main agent is daptomycin. It has good coverage for methicillin-resistant Staphylococcus, vancomycin-resistant Enterococcus, and Enterococcus faecalis. Next is polymyxins. These group of antibiotics interacts with cell membrane. So they binds to phospholipids, alters cell permeability, and damages the bacterial cytoplasmic membrane, permitting leakage of intracellular constituents. And they exhibits concentration-dependent killing. So the main polymyxins are polymyxin B and colistin, and it has got gram-negative spectrum, which covers E. coli, Klebsiella, Enterobacter, Pseudomonas, Acinetobacter. And the gram-negative spectrum of colistin does not, like polymyxins, does not include Serratia, Providentia, and Proteus. Like these organisms are intrinsically resistant to colistin. Next, we'll move on to tetracyclines. So from next part onwards, we'll be dealing with antibiotics which inhibit protein synthesis. So tetracyclines inhibit bacterial protein synthesis by reversibly binding to the 30S ribosomal subunit, and they exert the bacteriostatic activity. The main agents are tetracycline, doxycycline, and minocycline. So they have cover gram-positive aerobes, both methicillin susceptible and resistant Staph aureus. Then it has got spectrum. The spectrum includes gram-negative aerobes, but resistance is very common. And it has got anaerobic coverage and mainly atypical coverage, which includes chlamydia, mycoplasma, and rickettsia. Next is glycyl cyclines. They are structural modifications of tetracyclines to improve spectrum of activity. So they also inhibit protein synthesis through ribosomal binding. And the main thing is that binding to 30S is 5 times higher than that for tetracyclines. And they exhibit time-dependent activity with prolonged post-antibiotic effect. And the main agent is tigecycline. So tigecycline is a very broad spectrum antibiotic. It has got gram-positive coverage, includes gram-positive aerobes such as MRSA and vancomycin-resistant Enterococcus, and gram-negative aerobes including ESBL and Acinetobacter. And one exception for this gram-negative spectrum is that it does not cover Pseudomonas aeruginosa, and it has got anaerobic as well as atypical coverage. Next class of antibiotics is aminoglycosides. So aminoglycosides also inhibits protein synthesis, and they reversibly bind to the 30S ribosomal bacterial ribosome subunit, and they are bactericidal in a concentration-dependent manner. This class of antibiotics also exhibit post-antibiotic effect. The main agents under aminoglycosides are amikacin and gentamicin. So the gram-positive spectrum includes most Staphylococcus aureus and coagulase negative Staphylococcus, then virulence group Streptococci and Enterococcus species. Then the gram-negative coverage includes E. coli, Klebsiella pneumoniae, Proteus species, then non-fermentase such as Acinetobacter, then other enterobacterial such as Citrobacter, Enterobacter, then Morganella, Providentia, Serratia, Salmonella, Shigella, and Pseudomonas aeruginosa. Then it has got activity against mycobacteria as well. Next is macrolides. So they inhibit protein synthesis by binding to the 50S ribosomal subunit and suppression of RNA-dependent protein synthesis. It exhibits bacteriostatic time-dependent activity. The main agents under macrolides are azithromycin and clarithromycin. So it will cover gram-positive aerobes such as Staph aureus, only methicillin susceptible Staph aureus, and Streptococcus pyogenes and Streptococcus pneumoniae. Then the gram-negative spectrum includes H. influenzae, Moraxella catarrhalis, and atypical coverage such as Mycoplasma, Chlamydia, and Legionella. That is why we are using it as the first line of antibiotic for community-acquired pneumonia. And then Mycobacterium also. Then oxazolidinones. These are the next class of antibiotics. They bind to the 50S ribosomal subunit and inhibits protein synthesis and exerts bacteriostatic activity. And the main agent is linezolid. So it has got spectrum MRS of MRSA coverage, then vancomycin resistant Enterococcus faecium, and then Enterococcus faecalis. Then it has got atypical coverage as well, which covers Mycoplasma, Chlamydia, and Legionella. Next is lincosamine group of antibiotics, which inhibits protein synthesis by exclusively binding to the 50S ribosomal subunit. They usually displays bacteriostatic activity, but may be bactericidal at high concentrations against very susceptible organisms. And the main agent is clindamycin. So the spectrum of clindamycin includes gram-positive aerobes such as Staphylococcus aureus, Streptococcus pneumoniae, Viridans group Streptococci, but it will not cover Enterococcus species. It has got no activity against gram-negative aerobes. Then clindamycin has got excellent anaerobic coverage. So it covers anaerobes such as Streptococcus, Actinomyces, Propionibacterium. These are all gram-negative anaerobes, and then gram-positive anaerobes such as Clostridium, but not Clostridium difficile. And then some bacterioid species, Prevotella and Fusobacterium. So clindamycin has got excellent spectrum for above the diaphragm anaerobes, whereas it has no activity against anaerobes below the diaphragm. Next, moving on to antibiotics which inhibits the folic acid synthesis in bacteria. So first one is fluoroquinolone antibiotic. They inhibit bacterial topoisomerases which are necessary for DNA synthesis, and they exhibit concentration-dependent bactericidal activity. And the spectrum includes gram-positive such as MSSA, methicillin-susceptible Staph aureus, Streptococcus pneumoniae, including penicillin-resistant Streptococcus pneumoniae, Viridans group Streptococci, and then gram-negative organisms such as Enterobacteriaceae, Haemophilus influenzae, M. catarrhalis and Neisseria species, and Pseudomonas aeruginosa. It also has got atypical spectrum such as it will cover Legionella, Chlamydia, and Mycoplasma. Next, fluoroquinolones are divided into different generations. That is, the first generation is nalidixic acid. It has gram-negative coverage, but not Pseudomonas. And the second generation, such as ciprofloxacin, ofloxacin, has got gram-negative coverage, including Pseudomonas aeruginosa, and some gram-positive and atypical coverage. And then the third generation fluoroquinolones, Liverflox, Moxiflox, and all are having similar spectrum as second generation with extended gram-positive and atypical coverage. Then metronidazole is another agent. It inhibits DNA synthesis after diffusing into the organism, interacts with DNA to cause a loss of helical DNA structure and strand breakage, resulting in inhibition of protein synthesis and cell death in susceptible organisms. It displays concentration-dependent bactericidal activity. So metronidazole is mainly used for anaerobic activity. So the spectrum includes anaerobic bacteria such as bacterioid species, Fusobacterium, Prevotella species, Clostridium species, including Clostridium difficile, and then Helicobacter pylori, then anaerobic protozoa. Next comes the sulfonamide class of antibiotics, and the main agent is trimethoprim sulfamethoxazole or cotrimoxazole. So sulfamethoxazole interferes with bacterial folic acid synthesis via inhibition of dihydrofolic acid formation from paraaminobenzoic acid, and trimethoprim inhibits dihydrofolic acid reduction to tetrahydrofolate, resulting in sequential inhibition of enzymes of the folic acid pathway, and they displace bacteriostatic activity. The spectrum includes gram-positive pathogens such as MSSA, MRSA, coagulus-negative Staphylococcus, Listeria, and Nocardia, and gram-negative spectrum includes Aeromonas, Enterobacter, Serratia, Brucella, H. influenzae, Legionella. Then it is a drug of choice for Stenotrophomonas maltophilia infection. And next is nitrofurantoin. The metabolites alter or inactivate bacterial ribosomes and other macromolecules, preventing DNA and RNA synthesis, aerobic metabolism, and cell wall synthesis. Nitrofurantoin is bactericidal at higher concentration in urine, and it is used for the treatment of uncomplicated UTI caused by E. coli on Staphylococcus saprophyticus. And next agent is fosfomycin. It is a phosphonic acid derivative. Fosfomycin inhibits bacterial cell wall synthesis by inactivating the enzyme pyruvyl transferase, which is critical in the synthesis of cell walls by bacteria, and it displays bactericidal activity. And the spectrum of fosfomycin includes E. coli, Citrobacter species, Enterobacter species, Klebsiella, Serratia, and Enterococcus species. So I have provided the spectrum of activity, but it is not the complete list of organisms covered by this particular antibiotic, but the common pathogens covered by these antibiotics, and also where these antibiotics are the first line of choice or a potential alternative for infections caused by these pathogens. Now we'll discuss the first sample question number 1. So in this case, the culture and sensitivity report was showing Pseudomonas aeruginosa, which is pan sensitive, but as we have discussed earlier, amoxicillin clavulanate does not have anti-pseudomonal activity. Hence, we'll have to escalate the antibiotic to cover Pseudomonas aeruginosa as well. So C is the correct option. Next, the sample question 2 is the empiric therapy for infective endocarditis. So here I have mentioned that the empiric therapy should cover Staphylococcus, both methicillin susceptible and methicillin resistant, then Streptococcus and Enterococci. So the antibiotic which covers all these pathogens is vancomycin. Hence, vancomycin is the drug of choice. The key takeaways of this presentation is the knowledge of antibiotic spectrum plays a vital role in the appropriate selection of antibiotic regimen. It improves clinical outcome by prescribing antibiotic with adequate coverage, avoiding therapeutic duplication, decreasing ADRs and costs. Empiric therapy of an infection requires antibiotic coverage for all the possible pathogens causing that particular infection, which can be later optimized based on culture and sensitivity report. And the clinical judgment of the patient's condition should be prioritized while selecting antibiotics. So these are the references, and thank you. If you have any questions, I'll be happy to discuss them.
Thank you, Dr. Disha, for the insightful presentation. So we have some questions. So can I go ahead with the questions?
Yeah, sure.
So the first question is, what are the common antibiotic interactions in a hospital?
Common
antibiotic interactions in a hospital.
Antibiotic interactions, yeah, maybe interactions can be based on the, like, it is not mainly based on the spectrum of activity, but based on the pharmacokinetic activity of those antibiotics. So commonly seen antibiotic interactions are like if we are maybe nephrotoxic drugs, such as if we are giving two nephrotoxic drugs together, such as aminoglycosides and colistin, so it will result in severe renal failure for that patient. So that is one thing, one interaction which we encounter in very commonly. And there are many interactions with antifungals as well. I think this topic will be dealing later in the pharmacokinetic session.
The second question is, which organisms are covered by oxazolidine?
Oxazolidine.
Yeah,
linezolid has got MRSA coverage, and it will cover vancomycin resistant Enterococcus as well, then Enterococcus faecalis, and it has got gram positive anaerobic coverage as well.
So the third question is, does the triple drug therapy still an effective option for H. pylori?
Yeah, H. pylori infection requires that is a standard therapy, like triple drug combination.
So the fourth question is, can you explain more on superbugs?
Oh, okay. So the resistant bugs such as carbapenem-resistant Enterobacter, then carbapenem-resistant Acinetobacter baumannii, then difficult to treat Pseudomonas aeruginosa. These are all the superbugs. So the antibiotic drug of choice for this for these infections are very limited, and hence it is very essential to do antimicrobial stewardship, whereas we can inhibit the decrease the unwanted use of these reserve antibiotics, which are the main drug of choice for this superbugs.
Okay, the fifth question is, what are the most commonly used broad spectrum antibiotics?
Commonly used when it comes to our setting, if mainly if a patient is coming as hemodynamically unstable condition, we'll be covering the covering most gram positive as well as gram negative bugs. So BLBLI, beta-lactam, beta-lactamase inhibitors such as either a piperacillin tazobactam or cefoperazone sulbactam will be the first line of choice, and then with clinical improvement and with the availability of cultural and sensitivity reports, we'll be optimizing the antibiotic.
The sixth one is, could you please explain once more the sample question 1?
Okay. So the this question is mainly the patient presented with respiratory syndrome, and we have provisionally diagnosed it as lower respiratory tract infection, and patient was prescribed amoxicillin clavulanate empirically, because we have sent the culture, then prior to obtaining the evidence, that is the culture and sensitivity report, we have started this antibiotic. So, and when the sputum culture report was obtained, it shows Pseudomonas aeruginosa, which is a pan-sensitive bug. That is pan-sensitive in the sense all tested antibiotics are showing sensitivity, are sensitive against this organism. But as we have already discussed, the amoxicillin does not have anti-pseudomonal activity. Hence, we'll have to increase the spectrum of activity of our current regimen, current antibiotic, that is amoxicillin clavulanate. We'll have to add something which covers Pseudomonas aeruginosa as well. Hence, we should escalate the antibiotic to include anti-pseudomonal activity as well. That is, we can choose either a piperacillin tazobactam, or if the patient is getting better and can tolerate oral medicines, we can opt for fluoroquinolone such as levofloxacin, like that. Is that clear?
So, yeah. So the seventh question is, as clinical pharmacists, what all are the steps that we can follow to reduce antibiotic resistance?
Yeah, the main thing is antimicrobial stewardship itself. So in antimicrobial stewardship, we are assessing whether the antibiotic is required for that patient, whether the appropriate antibiotic is selected, whether it's even antibiotic is indicated or not, and whether the selected antibiotic is appropriate, whether we can de-escalate it, or if escalation is needed for that particular patient, then the dose, frequency, all these factors are contributing to antimicrobial resistance. That is, if we are giving a subtherapeutic dose, the development of resistance is there will be selection of resistance among bacteria. So while looking all these things, we can play a significant role in reducing antimicrobial resistance. And of course, the duration of antibiotics. We have to stop the antibiotics whenever it is appropriate based on our focus of infection and on the based on the clinical condition of the patient. Mainly, clinical pharmacists play a main role in this dose optimization part, and also all these area we can contribute, but mainly dose calculations such as based on creatinine clearance. Then patients with hepatic impairment may also need dose adjustment for certain antibiotics such as tigecycline. So in all these cases, we can contribute. Then also with drug interactions and ADRs and maybe IV to oral switch, that is a potential area for clinical pharmacists to intervene. Yeah.
So
Any
the
more?
eighth question is, what all are the most common hospital-acquired infections?
Most common hospital-acquired infection, yeah. Hospital-acquired infections include mainly the CLABSI, central line associated infections are there, then hospital-acquired pneumonia, then surgical site infections, then catheter-associated UTI. So these are all the common hospital-acquired infections which we are encountering.
Okay. So the ninth question is, what would be the criteria to choose an antibiotic if there are multiple antibiotics with similar profile? For example, there are different cephalosporins because different classes of cephalosporins. So in each generations.
So that will be depending on the focus of infection, like which is your suspected focus of infection. So this antibiotic should achieve adequate concentration at the site of infection, and then the patient's clinical condition, that is, if the patient is having renal impairment, hepatic impairment, all these factors you need to consider. Then the age of the patient, then whether the patient is immunocompromised or not. Like when it comes to immunocompromised patients, we will not go with lower classes like antibiotics with lower spectrum. We'll mostly start with higher spectrum of antibiotic, that is, in a neutropenic patient and all, we'll start with carbapenem itself. So then later, based on clinical improvement and recovery of neutropenia and all, we'll be coming down, like de-escalating the antibiotics.
Okay, I think that is the end of the questions. Thank you once again, Dr. Jisha, for the insightful presentation, and your expert has truly enriched our discussion today.
Thank you, Dr. Ajay.
So before concluding, I will just go through the upcoming events once more. First, we have CP Conclave 2023 that is organized by Ahmedabad School of Pharmacy in collaboration with FCPA on 15th and 16th of November 2023. The CP second is the CP Summit 2023 organized by Indian Pharmaceutical Association Students Forum on 25th and 26th of November in Pune in collaboration with FCPA. And third is the ID Congress 2024 that is organized by ICRA Hospital Calicut from 19th to 21st of January 2024 in collaboration with FCPA. So that's all for the today's session, and please follow our social media platform for more updates.